So I am presenting NP, a female. She's a Uganda. She's an Anglican and a single mother, and she's a food vendor. She's from Kisasi, and the next of kin was SB, and that was the daughter. The date of admission was 6th of Feb 2018, and she was discharged on the 23rd of Feb. She presented to Chibudu with a history of loss of consciousness for 5 hours prior to presentation at Chibudu. Importantly, this was collateral history from the neighbor who brought her and a relative. So NP had diabetes type 2 for more than 6 years, and she had been on a combination, a dose of mixture. However, we did not know the exact dose which she was on, and she could not tell us because she was unconscious. And importantly, she was found unconscious with a plate of food next to her, and this was by a neighbor who was passing by. Therefore, the circumstances surrounding how she fell and how she became unconscious were not clear. And importantly, the guardians who stays near her had reported that she had had a 3-supper insulin dose, though we don't know how much, and she had had a supper. And also they told us something very important, is that she usually woke up at night to eat because of excessive hunger. And that had been happening for a long time, and therefore it was normal to them. And something also very important, she had no history of convulsions or fever prior to this situation that happened. In the review of systems, these were not assessed because the patient was comatose. Significant findings in the past medical history, or by the time of admission, is that when she was diagnosed with diabetes 6 years prior, she had undergone an amputation. Therefore, she got to realize she's diabetic through a diagnosis of a gangrenous right leg, and therefore she had to undergo amputation. And then after that, she had a problem with her eyes. She developed poor sight, and she underwent surgery 2 years prior to admission. This is important because even though she underwent the surgery, she always told her relatives that her eyesight never improved. And in the family history, she has one brother who is hypertensive and diabetic, and she lost her husband due to complications of diabetes. She only has one child who is who is diabetic, who is hypertensive, but not diabetic. And in the social history, she's a retired teacher. If you notice, she's 53 years old, but she had to undergo early retirement because of poor vision. And she also quit alcohol before, and she had never smoked. But also what was quite disturbing in the social history is that despite all these confounding things that she had, she stayed alone, and she only had an occasional helper who would come to ensure that she injects herself with the right dose of insulin and at particular times. And importantly, she cooked for herself. Even though she had reduced vision, she could cook for herself. So in summary, NP was a 53-year-old female, non-diabetic for more than 6 years, who was found unconscious with a plate of food next to her, and she was subsequently brought to Chirudu Hospital. And also she had a previous history of amputation and eye surgery. It was for cataract. So at that point, the first differential diagnosis was hypoglycemia in view of the recurrent history of waking up at night to eat. So maybe we thought this time it was maybe too much, she couldn't eat in time. Then cerebrovascular accident in view of she's a hypertensive, she's a diabetic patient, and there is increased cardiovascular risks in diabetic patients. Intoxications and poisons, because we are thinking, imagine you come and find someone unconscious with a plate of food next to them. Among the differential diagnoses, it could be a poison. She could have eaten something that maybe made her unable to finish whatever she was doing. Then a post-ictal phase of convulsions. Even though in the history there was none about previous history of convulsions, but sometimes you could have a breakthrough and you never know. And therefore she was probably in the post-ictal phase. And we also thought about myocardial infarctions and arrhythmias presenting in syncope because of a history of diabetes. And by the time she had peripheral artery disease requiring amputation, probably it could have also affected the heart, and therefore we thought of probably a myocardial infarction with an arrhythmia that sent her into syncope. Then the last but not least was a traumatic brain injury. Now this is in view of probably she woke up, fell down and unable to eat, or even maybe someone broke into her house and hit her and we don't know. So this was our differential diagnosis before examination. So when we went further and examined her, she was a sick-looking middle-aged lady in good nutritional status with a few bruises around her face. And she was lying flat in bed, and her random blood sugar at that point in time was 1.9 millimoles per liter. She was already on oxygen and had an NG tube, and she had an amputated right lower limb below the knee, and she had mild pallor, no jaundice, no lymphadenopathy. She was afebrile with no edema. In the CNS exam, she had a total score of 8, whereby in the eye opening she scored 2, motor 4, and verbal 2. Her neck was soft and canines was negative. And the cranial nerves at that point could not be fully assessed because she was a comatose lady, although she did not have any facial asymmetry. Therefore, you could almost try, by inference, predict that probably cranial nerve 7, the motor aspect is normal. Then her right pupil, she had a cataract. It was a mature cataract. And the left eye was slightly reactive with a cataract not very mature. And therefore, in view of this, fundoscopy could not be done because it was an opaque lens. You could not see behind the eye. In the motor exam, by the time of admission, you can notice both the upper limbs and the lower limbs on both sides had reduced tone, had reduced reflexes. Horsepower, we could not ask her to move. And we were also unable at that point to do a sensory exam because she's a comatose patient and sensory exam requires a lot of cooperation from the patient. In the cardiovascular exam, importantly, she had a blood pressure of 214 out of 149. Her heart rate was 55 beats per minute. It was regular, normal volume. The jugular venous pressure was not elevated. The heart points 1 and 2 were hard, and it's important we should add that the apex beat was not displaced. The respiratory exam, she had a respiratory rate of 30 cycles per minute. She was saturating 96% in room air, although we saw it fit to give us supplemental oxygen. Her chest was symmetrical in size with equal chest expansion, though she had reduced vesicular breath sounds in the left infrascapular region. And there wasn't anything significant on abdominal exam, and we also did not go ahead and do a rectal exam. Therefore, the impression at that point was hypoglycemia, because we have evidence of it, an RBS of 1.9, with hypertensive encephalopathy, because of very high blood pressure, and someone who is comatose, you could think about hypertensive encephalopathy. Next was a stroke in view of history of diabetes, and now we have realized she's very hypertensive, so stroke was a third one on the list. Fourth was aspiration pneumonia, because she had, although it was not a very classic picture, she had reduced vesicular breath sounds on the left. Classically, it should be on the right, but it also depends on the position of the patient by the time they aspirate. And we still maintained a traumatic brain injury in view of the reduced GCS and the bruises on the face. So we still maintained traumatic brain injury. And also, if you remember Cushing's triad, whereby you have hypertension, bradycardia. So, and you remember she had a BP, a high blood pressure, and a low heart rate. So still, traumatic brain injury was still amongst our impressions at that time. So, our management for the different problems that she had, we classified them. For the hypoglycemia, we gave her 30 ml of 50% dextrose, and we ensured it is flushed after the infusion, and we monitored the random blood sugar for her. For the aspiration pneumonia, she was put on metronidazole intravenous with ceftriaxone, and that was to last 5 days. For the hypertensive encephalopathy, she was given intravenous labetalol and amlodipine. It is important to note it's only, in most cases, it's only when someone has a probable hypertensive encephalopathy, whereby intravenous drugs for hypertension are indicated. Then for other modalities in our management, we also wanted to investigate further, and therefore, apart from putting an NG tube and a catheter and oxygen, we also wanted baseline tests like a complete blood count, renal function, liver function tests. We also wanted to do a chest X-ray, brain CT scan, ECG, and echo. At this point, we did not account for the probable increase in intracranial pressure secondary to traumatic brain injury. But the IV labetalol was for the hypertensive encephalopathy, which can also present with signs of cerebral edema, although the management is intravenous antihypertensive, which show a very good outcome. So we did not give a mannitol or furosemide at this point. Some of the results that came is a complete blood count, and the significant findings that the neutrophils were increased, the percentage. HB was normal and the platelets were normal. And in the renal function tests and liver function tests, everything was within the normal range. We went ahead and did a chest X-ray. I think you can all see it. It was not very classic of any pathology going on, although, yes, it was not very classic, but yes, that was a chest X-ray. Okay, it was not classic of aspiration pneumonia, although it also matters at what point you take the X-ray after aspiration. Radiographic changes only happen after 6 to 8 hours after the insult. And this chest X-ray was around the same time of admission, but there's nothing really much in the chest X-ray. Then we did a brain CT scan. Now, the report from the brain CT scan, and I quote, they said there are tiny hypodensities in the left insula and the base of ganglia. However, when we looked at the CT scan manually, we could not see any pathology. Of course, when the radiologists do it, they have many images and they can expand and do everything. But even then, they said there are tiny hypodensities on the left insula and the base of ganglia, which, yeah, probably they were there. However, on gross inspection of the CT scan, there wasn't anything suggestive of pathology. Now, this brain CT scan, in as much as we said initially she was, stroke was among our differential diagnosis, we were mainly banking on hypoglycemia. Okay? However, she did not regain full consciousness even after reversal of the hypoglycemia, and that's why we really encouraged them to do the CT scan. Although they said they were constrained in terms of money, we really encouraged them to do a brain CT scan. And this CT scan came at least 6 days after admission, But the major indication was failure to regain full consciousness even after reversal of the hypoglycemia. Now, a summary of what we did between the 6th and the 23rd, we kept monitoring her blood sugar and her GCS and her blood pressure. As you notice, she came with a very high blood pressure, which we tried to maintain. Now, her random blood sugar kept on increasing until the 9th, whereby it was again going on the upper side, and at this point we decided to put her on a mixed 5 international units in the morning and 5 international units in the evening. Now, with that regimen, she ended up getting another hypoglycemia on the 19th, although it was not clinically relevant. I say that it was not clinically evident. I say that because she was still talking, and you notice her GCS had improved, but yes, we noted a hypoglycemia, and therefore on the 19th, we stopped the mixed insulin which we had put her on, and we switched her to metformin, 500 milligrams twice a day. And you can notice her blood sugars were not so bad, and by the time we discharged her on the 23rd, she had a GCS of 14, and her blood pressure had come back to within almost normal ranges. And yes, that's what, this is a sign of our monitoring while with us in the endocrinology ward. So the current status of the patient by the time we discharged, she was discharged on the 23rd, and with a number of medications, metformin, because we realized even with a small dose of insulin, she was a candidate for another hypoglycemia. Then we put her on nifedipine and captopril. Nifedipine is a calcium channel blocker, and calcium channel blockers are the first line treatment for Africans who are hypertensive. But we also added captopril. Captopril is an ACE, and ACE inhibitors are the best choice of antihypertensive in a diabetic patient. Then we also put her on atorvastatin, because in any person who has suffered a stroke, and most times the cases are probably ischemic, they are supposed to be on atorvastatin. But also atorvastatin has protective effects on the cardiovascular system, because she already has risks of, she is diabetic and she is hypertensive. So that's why we also put her on atorvastatin. Then we also put her on aspirin, cardiac aspirin, 75 milligrams once a day. As I said earlier, her GCS had improved to 14 or to 15, and we advised her to go on follow-up in both the endocrinology unit and in the neurology unit. So that's the summary. Yes.